Hi, I'm Dr. Aubrey Armento, pediatric sports medicine physician at Children's Hospital Colorado.
And I'm Amanda McCarthy, registered sports dietitian and program coordinator at Children's Hospital Colorado Sports Medicine Center.
Amanda and I work together at the Sports Medicine Center to provide comprehensive care to young female athletes who have unique needs. Today, we are going to talk through some common myths and misconceptions about female athletes related to sports medicine and nutrition. Let's get started. Number 1, it is normal for female athletes to lose their period or have irregular periods when they are training and competing. This is false. We can never assume that it is normal for a female athlete to not have a period or have irregular periods. While some menstrual irregularity can occur in the first few years of menarche in healthy adolescents, having irregular periods can also be a sign that an athlete is not getting enough nutrition to support their exercise and normal physiologic functioning. This is called low energy availability, which can lead to relative energy deficiency in sport, or what we call REDS. Not having a regular period, or amenorrhea or oligomenorrhea, is associated with REDS. I always recommend young female athletes with irregular periods see a sports medicine physician or sports dietitian to further evaluate for low energy availability. Number 2, athletes with a weight or BMI in the healthy or high ranges can have low energy availability and relative energy deficiency in sport. This is true. While a low weight or BMI is considered a risk factor, an athlete does not have to be underweight to have REDS. In a state of low energy availability, the body works to conserve energy by reducing resting metabolic rate, which can lead to weight maintenance or a lack of weight loss. We should never assume that an athlete is not at risk for REDS based on their weight or BMI status. Additionally, in athletes at higher weight or BMI who lose weight, especially a rapid decline in weight, further evaluation should be performed to understand the behaviors leading to the weight loss and to screen for eating disorders and REDS.
Number 3, eating disorders are not common in athletes. This is false. Eating disorders of all types are contributors to low energy availability in athletes, and low energy availability is a risk factor for the development of an eating disorder. The prevalence of eating disorders and disordered eating in adolescent female athletes is often higher than the non-athlete population, ranging from 6 to 45%. Factors that contribute to higher risk of developing an eating disorder in athletes include the following: participating in a sport that emphasizes aesthetic or weight, endurance sports, individual sports, overvalued belief of reducing weight or fat to improve performance, elite competition, pressure to alter body weight by coaches, parents, peers, or medical professionals, and maladaptive perfectionism in the athlete. Disordered eating can also impact an athlete's energy availability and includes athletes who are restricting their feeding patterns in some way, whether it be food types, the timing of nutrition intake, or restricting total nutrition intake. Most commonly, this includes experimenting with popular fad diets, which often mimic adult fad diet trends. These patterns can have both physical and mental consequences, including poor endurance, poor growth, poor exercise recovery, declining overall performance, and poor mental health. Oftentimes, athletes don't realize that these eating patterns are detrimental to performance and health, and simple education can go a long way in improving nutritional behavior and preventing escalation of these behaviors to an eating disorder. If you have concern about an athlete's weight or nutrition behaviors, a registered dietitian specialized in both pediatrics and sports nutrition can help the athlete navigate their nutrition needs for growth, development, and sport. It's never appropriate to recommend weight loss or a specific diet to an athlete without first examining their past growth, diet, and exercise behaviors. It's also never appropriate for an adolescent athlete to be following a fad diet or tracking calories of their food intake without supervision from a healthcare provider, as these behaviors have been linked with eating disorder pathology.
Number 4, in a female athlete with amenorrhea, treating them with oral contraceptive pills will protect their bones or increase bone density. This is false. In amenorrhea, bone density is reduced due to the state of low estrogen and low energy availability. The formulation of estrogen commonly used in oral contraceptive pills has not been shown to be effective in increasing bone density. However, transdermal 17-beta estradiol, or the physiologic form of estrogen, has shown to improve bone density in amenorrheic athletes. The first line of treatment for low bone density associated with amenorrhea is nutritional restoration to address the low energy availability. Transdermal estradiol treatment, not oral contraceptive pills, can be considered as an adjunctive treatment option. A sports medicine physician or other healthcare professional experienced in female athlete reproductive care can help navigate these treatment options.
Number 5, iron needs are high for female athletes. This is true. Menstruating females have the highest iron needs of all adolescents at 18 milligrams per day. Other factors that increase iron needs include living or training at altitude, vegetarian or vegan diets, the training load, and a phenomenon called foot strike hemolysis, which happens in athletes with high amounts of running or jumping in their sport. Vegetarian vegan diets almost double iron needs for athletes, raising a menstruating athlete's needs to 32 milligrams per day. Early stages of iron deficiency without anemia are characterized by normal hemoglobin and serum iron, increased transferrin, and a fall in serum ferritin below 30 nanograms per milliliter. We recommend targeting a serum ferritin of 50 nanograms per milliliter or higher in female athletes. When adding supplementation, I recommend athletes take this on an empty stomach in the morning with a high vitamin C food. Some evidence points to rising hepcidin levels in the afternoon, which suppresses iron absorption. Very high fiber intakes, high intakes of calcium, zinc, or tannins from tea or coffee can also suppress iron absorption. In athletes prone to stomach upset or constipation from supplementation, the dietary upper limit for elemental iron is 45 milligrams per day. So prescribing a supplement at or below this level can help reduce GI symptoms.
Young female athletes have unique medical and nutrition needs. At the Sports Medicine Center at Children's Hospital Colorado, clinicians like Amanda and I have pediatric expertise in the comprehensive care of the female athlete, particularly for the growing adolescent athlete.
For more information about what we offer at the Sports Medicine Center, please visit childrenscolorado.org.